Okay, so let's start. Assalamu alaikum. Thank you very much for joining me today. My name is Dr. Mahin, and today we're going to discuss about some ultrasound cases as like before. So many of, sorry, just okay. So many of you have joined us on our previous sessions. Many of you are new to our channel. So this time we are going to arrange another session of ultrasound cases along with a bonus case topic, which we'll talk at the end of this session. So today we are going to talk about 5 ultrasound cases as like the last session, and we have reduced the number because 10 cases makes us a little bit toxic. So we just want to reduce the duration of the program so that it can be digestible. Anyway, we have a YouTube channel named Imaging Study. So if you're new here, joining as a new person, we have our previous sessions uploaded in our YouTube channel. So you can just go there and find them. Also, we have got 60K plus subscribers there, and also 469 videos, some of which may be beneficial for you. So, walaikum assalam. So, many of you have already got connected to me. If you have any question, you can just ask them into our Facebook live. Make sure uh, we are not available in the groups where we have already shared this content. But you can directly ask me any question if you have on our YouTube, Facebook live. My Facebook live is already open beside me, so I can just see what you are trying to ask me, and also the number of people joined there. So anyway, let's start. I'm just trying to make a delay because usually in my 5 case or 10 case sessions, the last case is the longest one. But this time, the first case is the longest one, so that people try to join as early as possible. So anyway, many of you asked me about where you can get the previous videos. So previous videos are already preserved in our Facebook page, Imaging Study, and also uploaded in our YouTube channel. So you can go and use your convenient method. Anyway, let's start with the case number 1. So this will be a pregnancy case. Usually I try to show you the pregnancy case a little bit later, but this time I'm going to show you this earlier. I'm very much sorry for the noise around me because there is a religious program going on outside my home. So there might be some noise over there, which I can't reduce actually. So I need to make a soundproof room, I think, for this purpose. Anyway, so let's jump into the case number 1. So this is a 20 years old female patient who came with an amenorrhea for 5+ months. She came for a regular pregnancy scan in a tertiary level government hospital when I was a resident there. And we found this case interesting. So let's share with you. So let's look at the head of the fetus first. So when we looked at the head of the fetus, you can see there is a herniated structure over here. This is a cystic structure with internal septation and a solid component, which indicates it to be an cephalocele. So it is connected to the occipital region. So this is the occipital cephalocele, and you can see the internal content is fluid. You can see some anechoic content. Let me freeze the image. So you can see, let me move a little. So you can see the content is a fluid content. You can see some membranes and internal solid components. So this is a case of occipital encephalocele. Okay, let's look at another one. So this is a case of occipital encephalocele. So if you find something like this, make sure you should check the brain for usual ventricles for ventriculomegaly, because in this situation the fourth ventricle may get compressed, obviously. So adjacent hydrocephaly will be very common. I can't speak Urdu actually. I have no idea about Urdu and Hindi, so I can only speak in Bengali and poorly in English because it's very difficult. I tried to learn a few more languages, but it's not easy for me. So it's like just a hi, hello type phrases, but I can't speak in any other language. Sorry for that. So anyway, let's look at this case again. So this is the occipital encephalocele. You can see there is a bony defect at this part and the brain matter herniates outside. So it's a very common case, and whenever you get, you should search for hydrocephalus, and obviously you shouldn't end your diagnosis at this point. So there should be something else present because this is a neural related defect. So there will be obviously some spinal issues going on, and these patients commonly come with multiple abnormalities. So if you find multiple abnormalities, you definitely should think about some aneuploidies. So let's jump into another one. So this time in this baby, you can see there's a big omphalocele going on here. You can see us bulging out of the um, liver and intestinal content. You can see even stomach is outside the abdominal cavity, but here you can see the heart. So this is not only the abdomen, rather it is a thoracoabdominal herniation. So you can see the heart is also outside the thoracic cavity, making the thorax a little bit smaller. So that makes us another diagnosis here. So heart is outside the thoracic cage, so you call it uh, ectopia cordis, and you see the omphalocele here. So whenever you see omphalocele and ectopia cordis together, there should be a diaphragmatic defect, there should be a sternal defect. So all these features combine it to be a case of Pentalogy of Cantrell. So this is a case of Pentalogy of Cantrell. In case of Pentalogy of Cantrell, you should search for multiple abnormalities. So whenever you see ectopia cordis, you see omphalocele, this is Pentalogy of Cantrell. Now try to search for other abnormalities. Like in this patient, there's a very common association is ventricular septal defect. Now, I tried a little bit to find the ventricular septal defect, but with this machine setup and this condition, it was very difficult for me. So just try to look for any obvious ventricular septal defect which could not be found in this patient. So if you can't diagnose ventricular septal defect in this case, you shouldn't think that the ventricular septal defect is absent here. You should think that we have missed the ventricular septal defect. So it's a very common association, so you should find that. Okay, so we have missed the ventricular septal defect here. Now, what else we can find? So in case of Pentalogy of Cantrell, encephalocele is a very common association. If you look for the vertebra spine, you will find spina bifida. If you go for the heart, ventricular septal defect. If you go for the abdomen, a very common association, another common association is the renal defect or renal anomaly. The common renal anomaly is the horseshoe kidney. So we'll look for that also. And also the echogenic kidneys are very common. And for the limbs, it's not common association, but you can also find some clubbing. So there are so many options going on with our poor setup. Let's find something. So this is a male fetus. You can see the penis and the scrotum over here. I don't do the gender determination in my personal chamber. It is now restricted in our country by law already. But in many parts of the world, you can go for the gender determination, especially the European countries, as far as I know. And again, I, for my educational purpose, want to check the gender of this patient, because if it was a female fetus, I would love to go for the urogenital sinus or any other congenital abnormalities in this patient. So as it is a male patient, I would love to go for or search for the urinary tract abnormalities more. So let's jump into another view. So here I'm just trying to search for the cardiac defect in this patient. Let's freeze the image a little bit. Try to see whether any obvious abnormality present. I can't understand the VSD in this patient. So if I can't understand the VSD, I would say that I have missed the VSD in this patient. You can't see any Doppler pictures here because I didn't save any image of that the time, because it wasn't my personal case. It was the patient came to our department and my colleagues called me to check the patient, and I was just astonished to see what they have actually got on their bed. Okay, uh, so there is an ectopia cordis, okay, but in this picture, you are looking at the heart, I'm looking at the spine of this patient. So there are some views of spine here, and in some part, the spine doesn't look quite good. So let's look at another view of the surrounding area. So here I'm trying to look for you can see the pulsation of the aorta here. But at this part, let me freeze the image at this part. This is not a good picture. I know that, but this is from 2022, so I can't check the records of this patient again. So, walaikum assalam. At this part, let me freeze it a little. So at this part, the spine should have some issues, in this part, I'm not sure about that. So if I'm not sure, I will say that I'm missing the abnormality. So anyway, let's ignore that at this point, but look at the kidneys of this patient. So I was searching for the kidneys in this patient. This is not a proper view to demonstrate the kidney, but this one should be the hypoechoic structure, should be the kidney. I was just confused with looking at this saved video today, oh, that was the kidney of this patient. Uh, so uh, there is something coming here. Let me freeze the image. So in this view, if you want to make this thing as a kidney, it was a kidney, but this is not a good quality picture. I'm sorry for that. So there is something going from right to left in this patient. So this is actually the isthmus, which is making a horseshoe kidney in this patient. So that was not satisfactory for us in this quality picture, but there should be a horseshoe kidney in this one. So we are suspecting the spinal defect as well as the horseshoe kidney in this patient, but we have already confidently said that this patient is having occipital encephalocele. A patient is having omphalocele along with ectopia cordis. So this is a case of Pentalogy of Cantrell. So you can see this is the occipital encephalocele. This is the defect of the occipital bone. There is also the picture of occipital encephalocele. A common differential is the cystic hygroma. In cystic hygroma, you won't see any communication intracranially. Okay, so the skin and the bones of the scalp will be intact. Okay, so here is another picture where you can see this is the omphalocele. There's the stomach and liver outside the abdomen, having a covering, obviously, and the heart is also outside the thoracic cavity. So this is happening due to the sternal and diaphragmatic defect. Together, it is called the Pentalogy of Cantrell. I think I have a video on my YouTube channel about the Pentalogy of Cantrell, so you can also check that video. So here you can see we have checked the foot in 5-finger view of foot. There is no attached tibia and fibula, so we are not suspecting any clubbing here. Okay, so another view. So why I was suspecting the spina bifida or spinal dysraphism. Here you can see these three are the ossification centers, but posterior ossification centers have a wide gap in between. Though it's a not good view, but you have to understand that this is the large omphalocele making the abdomen quite narrow. So this view is okay, but it doesn't look okay. So this one is not good for the spine. But here there was a suspected area where we were suspecting any defect. So it was a lower lumbar or mid lumbar region defect possibly. Okay, so anyway, so this was a case of Pentalogy of Cantrell, where we found the occipital encephalocele, ectopia cordis, and omphalocele. So you can also combine other points like sternal defect, obviously it's present, and the diaphragmatic defect, without which we couldn't find both together. And also there was two suspicion in this patient, which can be evaluated on fetal MRI or on follow-up scan, though the patient will go for termination. You can search for the horseshoe kidney or spina bifida. So it was in 2022 when I didn't have a good machine. But if it was at this time, it would be quite easy. But this diagnosis is enough for the patient to go for the termination. Make sure if you find this type of cases, two common aneuploidies are present. First one is the trisomy 13, in which we get usually some intracranial and facial defects, which was not present. And the second one is the trisomy 18 or Edwards syndrome, which is a very common suspected case in this one. Ooh, okay, now let's jump into the case number 2. So, this is another female patient. So this is a 30 years old female patient who came with seizure, history of seizure. So she had a long history of seizure. So let's see what we have got on ultrasound. What is this? So, oh, you can see the liver and the gallbladder here. Let me just check. This one is the gallbladder. So this is the right kidney of this patient. Okay. The right kidney doesn't look like a right kidney. Make sure this is a 30-year-old female patient. You can see this echogenic ball here. Let me freeze the image. Let me go a little bit backward. So you see this echogenic structure. Okay, so this is a round, well-defined echogenic structure. Let me ask you a question. If you find this echogenic structure or this echogenic lesion within the liver, what should be the diagnosis? We commonly diagnose it as a hemangioma. Hepatic hemangioma is a very common case, and we see this type of echogenic round areas within the liver, which may be single or multiple. Okay, so for the kidney, it might be angiomyolipoma, which is a common case. So let me think about the angiomyolipoma here. So let's look at the kidney, but the renal ecotexture is not quite understandable, you see. So you can see some vessels entering and going outside, okay. You have find a human angiomyolipoma here, but the overall view is not satisfactory. Let me show you another one. Here is another view of this kidney. You can see, let me freeze the image. Just let me go a little backward. So you can see some vessels entering into the hilum of the kidney or pelvic region. Okay, so we have seen some view of the sinus region, but overall the texture is not very good. Okay, so it looks like there are so many masses within this kidney. Let me freeze a little again. So if you look here, this is the part of kidney. You see this echogenic area here. Let me change a little bit. You can see this echogenic area is attenuating the sound. Let me show you. This look at this brightness and this brightness or echogenicity, whatever you say. So this echogenicity is slightly darker than this part. Why? Because this echogenic area is attenuating the sound. So you are seeing some echogenic sound attenuating area. Is this calcification? No. This thick area, if it was a calcification, there should be some large posterior acoustic shadow, which is not present here. So it's commonly looking like, I think, the fatty liver-like texture. So this is a fat content. Okay, so we have got some fat contents. We have got some mass-like areas, which is diffuse, innumerable. We can't measure the number of these mass lesions. So, oh, there is another one. We have found another big diagnosis here. I haven't actually checked this record content, record video. So I just saw the case. I just put it on my PowerPoint and just trying to show you. So here you can see this echogenic round mass here, which is also sound attenuating. So this is the fatty mass over here. So if I could find this one in an ovarian cyst, I would say, oh, it's a dermoid cyst. But for the kidney, it should not be think about dermoid. So thought about dermoid. So we can think about something else. So overall, let me summarize this case. So just let me show you a Doppler picture. So here we have put some Doppler over the kidney. Yes, there is some vascularity, but the overall regular renal vascular pattern is lost. So these mass lesions throughout the kidney, changing its ecotexture, are getting different type of vascularity from different parts. So this is a disorganized vascularity within the kidney. So let us make a summary. So what about the other kidney? The left kidney is also showing the similar picture. Like you see, this is the right kidney. I have measured it from here to here. So this echogenic fat ball is also present. If you look at the left one, it doesn't look quite normal, but you see the liver looks quite good and the spleen is also very good. So this large kidneys with very heterogeneous ecotexture with large mass-like areas are nothing but, you see the fatty content, you see the lipoma there, or you see the hemangioma-like pattern there. So make a summary of hemangioma and lipoma. So these are actually angiomyolipomas within the kidney. So both kidneys are uh, uh, I think my sound system is quite okay. If maybe the network system may not be quite good, but there should not be any issue with the sound, I think, because let me just inform me whether the sound is okay or not, because I think the sound should be good enough, unless my microphone is dead. No, no, microphone is not dead actually. So anyway, so you see, these are diffuse or numerous or innumerable angiomyolipomas in both sides of the kidney, or in both kidneys, which is a feature of tuberous sclerosis. Have you remember? Can you remember the history of this patient? Patient was a 30-year-old female patient who gave the history of seizure. So this is a case of tuberous sclerosis. Now, what you want to look for? Let me show you the left kidney, then we'll discuss it a little. So here you can see the left kidney. It obviously looks like the right one. Some echogenic and fatty mass lesions, some hypoechoic mass lesions. Overall, the texture is completely lost. Let me show you another one. You can see diffuse mass lesions, hypoechoic. So these are the muscle contents, and some fatty tissues, some echogenic area. So innumerable mass lesions within the left kidney. So this is a case of tuberous sclerosis. Now, another view. Now, if you find this type of mass lesions within the kidneys in a female patient, young female patient is common, okay? Patient is giving you the history of seizure, which may or may not be present. If you find multiple angiomyolipomas in bilaterally, then first thing that you should search for is the rhabdomyoma in the heart. So let's put the transducer over the heart. I don't have that picture here, but if you put the transducer over the heart, you will see some echogenic balls or mass lesions within the ventricles or atrium. So rhabdomyoma is a common association. What else you want to see? You just can go for an MRI, and on MRI you will see some cortical tumor, so which are actually associated with the history of seizure. So this is a case of tuberous sclerosis. So here's the picture of the right kidney and left kidney on Doppler, and you can see the regular vascular nature or pattern is completely lost. Even for the left kidney, it is slightly maintained, but for the right one, it is completely obliterated. So this is a case of bilateral renal angiomyolipomas in a case of tuberous sclerosis. If you see sometime the patient is okay, there is no hematuria, there is nothing abnormality going on within the abdomen, but having large kidneys, completely obliterated parenchyma, you should definitely think of renal angiomyolipomas in a case of tuberous sclerosis. Okay, let's come to the case number 3. So this is a 54-year-old female. So today is a Women's Day for us. So all 3 cases are female. So a 54-year-old female patient who came with right-sided headache. Okay, what can we do for headache? Okay, we have an option for headache. So headache patients may come to us for a superficial temporal artery Doppler. So this patient was sent to us for superficial temporal artery Doppler to exclude our giant cell arteritis. So let's see what we have got on ultrasound. So this is the regular setting with which setting I just want to see the thyroid of this patient. But this, you can see a glimpse of the parotid gland. You can see intraparotid some lymph node. Okay, this is not a part for us today, but we have just put our transducer, linear transducer, not this one, just entry to our ear, so preauricular region, which is the area for the superficial temporal artery, which is the end branch of the external carotid artery. So here, this one is the superficial temporal artery. You can see the anechoic lumen here. You can see some hypoechoic area. Okay, just make sure you have seen the hypoechoic area at the margin of the parotid gland over here. Let's put some color Doppler. So we have put some color Doppler. You can see some vein, and you can see the artery here, which is showing aliasing. In your books, you can find some aliasing type topics written, but in this case, usually it depends on your machine setting. So make sure you should ignore the aliasing unless you compare both sides, right and left. So forget about that. Let's look at the right side here. And you can see that this pulsatile vessel is the superficial temporal artery, which is very good. You can see it better. When we have put color Doppler, we can't see any surrounding hypoechoic thickening or something like that, which made us confused. So if you see the superficial temporal artery only in the long section, you will also get confused about surrounding thickening, which is the point for us today. So you can see some parotid gland over here. We are trying to see the facial branches of the external carotid. But here now you can see at the superior part, this was the superficial temporal artery giving the flow. Now let's adjust the B mode gain a little bit. Now adjusting the gain, it looks quite good now. You can see the hypoechoic surrounding area, but in long section it is not well understandable. But if you check the vessel on transverse section it's quite easily understandable. Let me show you the transverse one. Here on transverse section you can see the pulsation, but you can also see the surrounding hypoechoic thickening quite well understandable, which was not seen or understandable on the long section. So whenever you are trying to see the superficial temporal artery, you definitely should put the transducer longitudinally and transversely. So here on transverse section, you can see this hypoechoic thickening, which is the feature of giant cell arteritis. So, or superficial, you can say temporal arteritis. Okay, so let's look here. This is the hypoechoic thickening on long section without Doppler. And when we put the Doppler, the vessel or due to our false adjustment or error adjustment, it may not be well understandable. But if you see it on transverse section, you can easily see the surrounding hypoechoic thickening due to arteritis. So let's look at the left side or compare the left with the right one. So this was the right one on transverse section, long section. And then this was the vessel. We checked the diameter and we took the sample, which shows that the vessel is having 52 centimeter per second of flow. But on the left side, the vascular flow was a little bit lower. You can see the vascular flow was peak systolic velocity was around 36 centimeter per second, and the vessel diameter was slightly less, not very important. But on the left side, there was no hypoechoic surrounding thickening, which we have already seen on the right side. So this was a case of right-sided temporal arteritis, or which we commonly say as giant cell arteritis. So it's a very common case for headache. And if you see any patient coming with a severe headache over the temporal region, you definitely should check the temporal arteritis. Just use the linear transducers, put the transducer just into your uh, ear, not your patient's ear, and put it on longitudinal and transverse section. You will see the surrounding hypoechoic thickening. It may or may not cause any luminal narrowing or constriction. In this patient, there was no luminal stenosis present. So the surrounding hypoechoic circumferential thickening of the vessel wall is the most important feature. Okay, case number 4. So let's look at here. So this is a male patient. This is a 58-year-old male patient who came with a recurrent transient ischemic attack history. So, okay, I think this is a case from yesterday. The patient was sent to us for the carotid Doppler. So the second case of Doppler today. Let's see what we have got on ultrasound. So it is from the 2nd January, yesterday, I think. So let's look at the picture. So we have took sample from different parts of the right carotid system and vertebral system. So on the right common carotid, external carotid, and vertebral artery all show very good amount of flow, but not the right internal carotid. So we took the sample from the internal carotid artery, which is showing 13 centimeter per second. Like when we were students in our school, our teachers would like to say that, oh, my students, you don't have any brain. So if you don't have any brain, even without any brain, you need more vascularity than this one. So 13 centimeter per second is not enough to supply or provide nutrition to your brain. So definitely there should be something abnormality going on. And you can see it is a multiphasic wave pattern. You can see flow at the positive and negative direction, so towards the brain and from the brain direction, which is very unusual for the internal carotid artery. And there is no flow in this long part of diastole. So it should be abnormal. So we'll look at it later, but let's look at the left side. Left side looks quite normal. This is the normal pattern of the internal carotid artery. You see a good amount of diastolic flow. So throughout the cardiac cycle, the brain should get a good amount of flow. So this is the common carotid and internal carotid, external and vertebral artery on the left side. All of them are showing very good amount of flow. Though there was some wall thickening over here, but the flow pattern is quite good. So there is no hemodynamically significant stenosis possibly. Okay, so let's jump into the right internal carotid artery. So this is the right internal carotid artery. I have taken sample from different parts of the neck, and now you can see this is the internal carotid artery proximal part, which I've shown you. It's showing 13 or 14 centimeter per second of flow, very bad. We have took sample from different parts, and now you can see it's a very little amount of flow, and it's a bidirectional flow. Like at a part of systole, it's giving flow towards the brain, and at the diastole, it's giving flow air from the brain. So it indicates that there should be something obstructing at the distal part. So the blood is trying to go out upward, but getting failed. So it's getting backward. So this is a bidirectional flow indicating distal severe stenosis or occlusion. So let's look at some videos. So we took sample from here, and you can see this type of flow. It's not moving, okay. But if you look at the beam mode image here, you can see some visible flow here. Let's look at that part. So this is the proximal part of the internal carotid artery. With your naked eye, you can easily see the flow is coming backward. You know, it should go on that side, but it is coming out from the brain side. So this is definitely indicating there is a severe stenosis at the distal part. But you can't see this type of echogenic plaques at the distal internal carotid artery in the neck region, which indicates that there is soft plaque at the distal internal carotid artery causing this occlusion. Okay, let's look at some other picture here. So I have changed the presets to search for the obstruction site. Uh, you can see this movement here. The bloods are coming out from the internal carotid artery towards the carotid bulb. So let's look at another one. You can see, yeah, it's just a sluggish flow which is going backward, trying to go towards the brain, but getting failed, so getting up backward. So it indicates there is a significant stenosis, or obviously it's complete obstruction at the distal internal carotid artery. So we try to check the flow here. Sometimes we can see some flow here and there, but it's not a good to detect the lumen quite well. So it indicates there is a complete obstruction at the distal part. You see some blue and some red because some flow are going towards the brain and some are coming back from that part. So we took the sample. You can see very sluggish amount of flow with no flow to on the diastolic component. This patient also had some other stenosis. So we checked the surface areas reduction in this patient, and there's so many plaques. Yeah, there is a significant, yeah, this is the internal carotid artery proximal part, which was showing the around 80% of surface area reduction, not the diameter reduction, this is the surface area reduction. And if you go further, there was no detectable flow, so it was very difficult to measure the complete obstruction. Okay, it's also not needed. Anyway, so overall, this was the feature. So if you follow the guideline of the consensus guideline from 2020, which was made by vascular medicine and vascular surgery specialist, and also the vascular ultrasound specialist, which is commonly available on the internet, you will see that the right internal carotid artery occlusion case was described there as this manner. So the right internal carotid artery waveform demonstrates an atypical high resistive pattern with a small reverse flow phase in late systole and absent diastolic flow indicating distal ICA occlusion. Okay, so this is the case of internal carotid artery occlusion along with other features. Okay, so the last case of today. So this is a 64-year-old female patient. So today we are female dominant situation going on here. I actually don't look at the gender of the patient. I just try to check the findings. But it is important. You have to understand how many people are coming to you, how many of them are male and female, so that you can understand the situation of the condition in the patient bank, like how many patients are female coming and how many are male coming to you. So this will be helpful to understand the ratio and understand the disease process, obviously. So anyway, forget about that. Let's jump into the case number 5. This is a 64-year-old female patient who came with for just a routine checkup. So 64 years, remember that. Let's see what we have got on ultrasound. It was an interesting case. The patient came with her youngest daughter, actually, who is also, I think, 40 plus years old. Okay, so let's see what we have got on ultrasound. So this was the patient's uterus on longitudinal transverse section, which is not a significant finding. It looks quite normal with my poor resolution. And here, this patient was also given to check the pre-voidal and post-voidal residue. So for first voiding, this was the post-voidal one. Overall, it looks quite okay. I have nothing to say about that. It's not the point for today. But if you look here, you can see this is the urinary bladder post-voidal situation. What is this? You can see some echogenic structure here that took our attention. But this is the post-voidal one. We have already checked that on pre-voidal state. So let's look at that part. So this is the longitudinal section of the urinary bladder. We are checking this structure here. So it is anterior to the urinary bladder, and you can see this is an echogenic structure. So two echogenic structure, this one and this one. So it might be two echogenic structures, which is already got slightly calcified or something, but it doesn't look like a calcified one. If it was a calcified, it should cast a very dark post-acoustic shadow. Uh, and it is not a good area for finding a calcified structure. So it is a very unusual structure. So you can see ecogenic, yeah, it may be a continuous structure like a U shape, or it might be a folded structure. So I took the history of this patient. Like, have you gone through any surgery recently? So patient gave me no history of surgery. So I tried to go a little backward. Like, when is there any history of any cesarean section or something like that? So because there was a scar mark at the lower abdomen. So patient said that yeah, she had a cesarean section done in 1976. Make sure it is very unusual at that time for going for a cesarean section. So it was 1976 when her youngest daughter born, and this structure here is nothing but the gossypiboma, which is a surgical gauze which was left within the abdomen. So why it is considered as a surgical gauze? It's a very simple. It is folded. You can see two echogenic lines here like this. So we put the gauze like a folded manner, and the size. We check the measure size of this lesion. Let's check so that we can understand whether this is a gauze or this is a surgical mob or something like that. Let's look at from different angle. You can see this structure here. So it is just entry to the urinary bladder, where you put that a mob or gauze to just hold the bladder or something like that. Much better than me. So this echogenic structure is the foreign body, which is forming a granulomatous lesion or granuloma here. So these two folds, this is the upper one, this is the lower one. So all looks quite similar and should be continuous with each other. So here you can see another view. These are the two echogenic linear structures, which are counted as a foreign body at the anterior part of the enter to the urinary bladder. So we took the measurement of both measures similar. So definitely it's around 3 centimeter. So let me check my remote here. So 3 centimeter structure should be a gauze. Okay, so this is a surgical gauze entry to the urinary bladder, which was left on 1976. So this is 2025 already, but the patient was from 2024 February. So that's a long history of around how much here? It was a big difference. Okay, so this is a long history. So patient no need for a removal of this one for last 50 years. So we don't want to focus it right now. So we suggested the patient if she goes for any CT or X-ray, she should look for this structure on that part. Okay, so this was a case of gossypiboma, the surgical gauze entry to the urinary bladder. Okay, so the gauze is more senior than me. So it has a history of 48 years, I think. Big time. Okay, so that's all for today. Thank you for joining me. Oh no, there is a bonus part here. So let's jump into the bonus part. Now, I was confused about choosing the bonus part today because I was in a rush. I was playing game for last, I think, 2 or 3 hours. So I actually missed the time. So that's why I was confused about choosing the appropriate one. So I searched for multiple lectures and just looked at an important topic. Sometimes I get question about that part. So let's talk about the ductus venosus. So it's a very common vessel that you need to check during the obstetric Doppler, and it is commonly ignored vessel as far I see during your obstetric scan. Why it is ignored? It is not ignored as it has a low value or high value. It is ignored because sometimes it makes difficult to find the ductus venosus So let's see how we can easily detect the ductus venosus in patients. So what is the ductus venosus? In fetal circulation, we have got a placenta as an oxygenator. So it purifies the blood and sends it back to the fetus through the umbilical vein, which carries the oxygenated blood. So this oxygenated blood, when comes to the fetus, if you supply whole of this blood to the liver will get congested. So we make a shunt here, which is called the ductus venosus. With this shunt, we put the blood to the inferior vena cava. Then inferior vena cava carries this blood to the right atrium. Then from right atrium, we transfer the blood to the right ventricle. And if you transfer all of this blood to the lung through the or pulmonary trunk, the lung will get congested. So we need more shunts here. So that's why we produce the foramen ovale, from where the right atrial blood goes to the left atrium, a maximum blood, then to the left ventricle, and through aorta we supply the whole body. And from the pulmonary trunk, we also make another shunt, which is called the ductus arteriosus, through which we send the blood to the aorta, so that the lung not get congested. So now let's jump into the ductus venosus. So this ductus venosus is carrying the blood from the umbilical vein to the inferior vena cava. So it is a one-way communicating pathway. It doesn't carry blood to the umbilical vein unless there is a huge pressure over the right atrium or there is any defect at this part. So ductus venosus actually gives us information about the fetal current condition, not the overall hemodynamics, how much fetus is getting affected. You can get this information from this ductus venosus because it will get affected when the heart is already got affected. So this ductus venosus is a connecting vessel from umbilical vein to the inferior vena cava, and it's a very valuable vessel for us in the second trimester or late first trimester NT scan time. When if you see any abnormality in ductus venosus flow, you should think about aneuploidy. Also in the late trimesters, if you find any ductus venosus flow abnormality, which will be it will be helpful to stage the intrauterine growth restriction or fetal growth restriction. And also at the late stage during the hypoxic condition of the fetus, if you find the ductus venosus flow is abnormal, we suggest to go for the delivery procedure or termination, but it depends from guideline to guideline anyway. So ductus venosus will always give you an antegrade flow towards the heart flow, and throughout the cardiac cycle there will be no gap. So the flow will be completely continuous. There will be no gap. So this is very important feature here. So you see it has got three waves like S wave, D wave, and A wave. We'll talk about that a little bit later, but make sure all the waves should be in a single direction from the upper part or lower part of the baseline. All will be on a same direction. No reflux should be present here. So now the question arises, why am I showing you these videos? Because you people ask me about how we can locate the ductus venosus, because it's a very complicated, very small size vessel. So sometimes it's very difficult to find out. Now, I'm showing you a poor quality abdominal circumference view. This is the cross section of the abdomen, which is a very easy view for everyone. It's a slightly oblique view, so you can see the heart here. Anyway, forget about that. So here you can see the portal umbilical vein entering into the abdomen, and it is giving a connection to the left branch of portal vein. So this is the liver. Okay, so in this type of abdominal circumference view, you should put the doppler. And if you put doppler, you'll see so many vessels here and there, but make sure one vessel will show you a color aliasing or a very light color. So the shunts are always having a very high speedy flow in comparison to the surrounding area. So due to high velocity flow, the shunts will show you aliasing or a very light color. Uh, the more the velocity, the lighter the color. So if you look at this picture, you can see only this part is showing some aliasing. So whenever you see the aliasing in a picture of abdominal circumference, this aliasing part should be counted as ductus venosus. So let's check that. So we have magnified the image. So on magnification, you can easily see this is the aliasing part, or showing the most light color or lightest color. So this is the part of ductus venosus. So this is the easiest way. You can also see it on long section, whatever you want, but make sure on abdominal circumference view, you'll see the aliasing, and this aliasing part will be ductus venosus. If you see aliasing in all the vessels, just adjust the pulse repetition frequency. So increase the PRF on a PRF setting where you see all the vessels are appearing normal. Ductus venosus will show aliasing because ductus venosus has more velocity than other vessels here. Okay, so we have took sample here, and now you can see it's giving you a very good W shape pattern flow. So this is the S wave, this is the D wave, and A wave is also present here, which is allowing the vessel to show you a complete or antegrade for continuous flow. So this is a typical picture of the ductus venosus. Now let's look at another view. Here, ductus venosus is connecting the umbilical vein to the inferior vena cava. So on ultrasound, we can see the aorta here. This is the aorta. This is the inferior vena cava. So we can also search for the communication between the inferior vena cava and the umbilical vein. So here you can see this is the umbilical vein, and there is a tiny little tract which is going to the inferior vena cava. You see, this is the inferior vena cava, this is the aorta, and this structure, this vessel is connecting the inferior vena cava to the umbilical vein. So this is the ductus venosus. So let's look at the video. Here you can see it's still showing some aliasing, and it's a tiny vessel which is connecting the inferior vena cava to the umbilical vein. So this is the ductus venosus. If you had a good machine, then you can easily use this type of view to demonstrate the ductus venosus. Okay, so here's another view where you can see the lightest color or the aliasing mixed color within the ductus venosus. These are the umbilical veins. You see, this is the umbilical veins entering into the inferior vena cava at this part. And this is the umbilical vein, and this is the aorta. Okay, now what about the poor quality machine? Let me show you a poor quality. This is not a poor quality machine, but it's an old machine, so the resolution got a little bit deteriorated. Now here, I was feeling confused, and this is a long section view. But here you can see this part here is within the abdomen, central abdomen, showing a little light color. It's not a little bit aliasing, but it is the lightest color here. So you put the cursor over here and take the sample. You will see this type of W-shaped pattern. And you see the continuous flow here, no reversal of flow. This is the S wave, this is the D wave, and this is the A wave, which are all in a same direction. Now, sometimes you may see some confusing waves at the opposite side, which may make you confused about the reflux. We'll talk about it a little bit later. Let's look at another view. So you see, this is the abdominal circumference view, not the good one, but it's a cross section of the abdomen. Okay, let's put some Doppler here. I have magnified a little bit, and now you can see umbilical vein entering into the abdomen, giving supply to the liver. And you can see this is the tiny vessel which is going to the inferior vena cava. So this is the ductus venosus. This one is the gallbladder, not showing any flow. Okay, so here now we have took sample. Now we are confident that this one is the ductus venosus, giving the W-shaped wave pattern. This is an early pregnancy of around 13 weeks, I think. The patient came for nuchal translucency scan, which is quite good. Now we have took a Doppler over the abdomen. Now you can't see any vessel going from the umbilical vein to the inferior vena cava at this age. So it feels a little bit confusing for you, but it's quite easy. And I found first trimester scan or the NT scan quite easy time for detecting the ductus venosus than the late pregnancy. So here you can see we have put color Doppler over the fetal abdomen, and now you can see a light color over here. No matter it looks blue or red, whatever it is, depending on the direction, but you see it is showing a light color. So you should put the pulse wave Doppler cursor to the lightest color area. Now on the lightest color area, you can see this pure W shape pattern over here. But you can see some backflows here. Now they may make you confused at early age. So we'll talk about that a little later. So the ductus venosus will show you the antegrade flow and towards the heart flow or towards the inferior vena cava flow, and throughout the cardiac cycle you'll see the flow. It has got three parts: S wave, D wave, and A wave. S wave means the ventricular systolic phase, A wave the ventricular, D wave is the ventricular diastolic phase, and A for the atrial contraction. Forget about that. So this S wave and D wave and A wave all will be present in a same direction. If you see any gap between two waves, if you see any gap and at this gap there is a reversal of flow, then you should think about the reversal of A wave. But sometimes it make you confused. I have told you that this type of flows on the opposite side may make us confused. Okay, so we usually don't do any measurement, and in this video, in this ductus venosus, there are so many measurements available. You can do the peak velocity index or a preload index. There are several measurement techniques, a little bit confusing. So if you follow or if you measure, you can just go for that measurement. So there are pulsatility index and S ratio. There are so many options available. So you may also practice those measurements. I don't want to go for this complicated part today. Okay, so let's jump into the abnormal flow pattern. Now, for the abnormal one, we have two common patterns. Number one is the absence of the A wave. So you may not see the A wave present at this part. You see both wave have got a gap in between. There is a gap here. So this gap is unusual. So if you find nothing, no flow here, you'll call it the absent A wave. And here it's not completely absent, rather you can see some reversal here. So this is the reversed A wave. Make sure to say it as a reversed, you should definitely see a gap in between two consecutive waves. So there is a gap here, there is a gap here, and you see the reversal. This is important, this is significant, and this is abnormal. But if you see the waves are continuous and there is a reversal of flow, it might be an artifact. So that may make you a little bit confused. So here is also another reversal of flow. The more the reversal, the more prominent the reversed A wave, it carries more significance. So it indicates the sign of cardiovascular instability. So the fetus may not having a good cardiac condition right now, so you definitely should go for the delivery procedure if it is suitable. So anyway, sometimes it may make you confused. So let's look at these two waves. So you can see uh, there are reversal. You see, this is the reversal of the flow at the A wave region, but this is not reversal. Why it's not reversal? You can see the waves are continuous. Like here, you can see these are continuous wave. There is no gap at this part. So if it was a reversal, there should be this like of gap. So here should be a gap, and at this gap part, there should be a reversal of flow. That is important. So if you see a continuous flow, you should not think about any reversal. There is no need for thinking about reversal. So the gap is very important. So here is another view where you can see there is a reflux here, but this is not the reflux from the ductus venosus. We actually make this type of wave patterns whenever we put the transducer or cursor. We take the sample from this part. Like here is a junction between the ductus venosus and inferior vena cava. So if you take sample from this part, you will see the flow from the inferior vena cava, which may come like this type of peak. Also, surrounding hepatic artery may make you confused. So this type of reversal like flow should be ignored whenever you see the vessels are having a continuous flow. Okay, so this is the situation here. This one was the normal picture where you see the continuation of the wave. So this type of reversals are from the surrounding vessel peaks, surrounding vessels wave pattern. But here you can see there is a gap in between these two waves, and there is a reversal at these points. The more the reversal part, the more severe is the condition. So we try to make a summary as this picture. You can see there is a gap. There is a gap between these two waves, and sometimes you may see some reversal of flow. So here's the reversal of flow, and there is a gap here. So adjust the picture a little bit so that you can get the best quality picture. So to make a summary, whenever you see there is absence of the A wave, it is the better condition. We say the better condition. And if you see it's having a reversed component or reversed A wave, this is the baddest condition. I use these terms for remembering the situation. If I say it's worse or worst, it won't be easy to remember. So if you see absent A wave, it will be better. If you see a reversal of A wave, the more the reversal, the more the baddest situation there. So that's all for today. Thank you for joining me. And our next session will be on 9th January. I won't be available on 10th January because our Radiology Society has a program on 10th January. So I won't be available in my place on that time, hopefully. So our next session will be on 9th January on Thursday, and we'll try to show you some interesting cases there. So if you're from my local country, we have a session on Doppler ultrasound in gynecological disorder. There's a paid session, and it will be available on Zoom tomorrow, and the whole curriculum or whole pattern or whole notice will be available and already available on our Facebook page. So you can check that if you're from. This is not available for the foreign people because we can't make any option for the payment and for refund for the foreign persons till now. So we have a YouTube channel where we have already uploaded our previous content, so you can just check them. This is known as imaging study, which is having 60K plus subscribers. Thank you for being with us for a long time, and we already have uploaded some videos there, so you can check them. And this video, today's case, will also be uploaded tomorrow in our YouTube channel, so you can also get that there as a recorded content. Okay, so, and also we have a YouTube, a website where we try to post our case, our notice. I don't know why I couldn't upload any picture yesterday. Maybe some issues there. So you can check some contents or notice there on our website, just if you need. Okay, so thank you for being with me for last more than 1.5 hour. So if you have any question, you can put down our Facebook Live so that we can try to discuss about that. People ask me about why I don't actually focus more on my YouTube channel nowadays. Like uh, right now, I have three running YouTube channels. And the first one is the imaging study. The second one is a gaming channel, which I'm trying to develop nowadays because I play a lot of games nowadays to make my mental pressure down. And another one is also irregular, which was made for my regular vlogging, but I didn't continue. But I need to continue actually. So, anyway, I hope I can post more videos in my YouTube channel in recent future. So anyway, thank you very much for being with me, and hope to see you soon again in our this free content program. Hopefully, in this month, we'll have five free contents. This type of case scenario contents. I think in every Friday or Thursday if I am not available on Friday. So hope this will be beneficial for you. If you find this video helpful, don't forget to share it with your friends. Together we can build a strong community. There's so many people from different parts of the world getting connected to us through these contents. Some are not having facilities for some case demonstrations and so many things. Some are not getting good internet connection also. My internet connection is not very good, but still I'm having a much privileged situation. So if we can contribute together, we can build a very strong community around the world. So thank you for being with me. 92% of subscribers of my YouTube channel are not from my own country. So it's a big point for me to make this type of content. So thank you for with me. Hope to see you. Yeah, I hope to meet you another day. I think on next year, on this year, I will have two international programs planned already. I'm trying to go for them. I'm missing one in this January. I had a paper and the presentation in AOCR, but I'm missing it from for some visa procedure or visa issues. But hope to see you all in Singapore in August and, if possible, Taiwan in May. So thank you for being with me. Hope to see you soon. Um, Enjoy. Yeah, thank you for being with me from different parts of the world. Thank you. Assalamu alaikum.